Well, I think one common misperception is that laser atherectomy is dangerous. The idea of using a laser within any type of artery sounds like it has inherent risks. And I think when laser atherectomy was first developed, it took a while to better understand the technique of using the laser so that in the initial phases decades ago, complications did occur more frequently. Nowadays, however, it's my strong belief that laser atherectomy is extremely safe and actually safer than any other atherectomy device. This includes the use of saline flushing when using the laser, and also attention to the speed of advancement of the laser catheter. By advancing the catheter very slowly at a rate of about 0.5 to 1 millimeters a second, it is possible to ablate the tissue in front of the laser without causing any distal embolization. Well, when I think about the laser learning curve, I consider it in comparison to other atherectomy devices, and frankly, laser atherectomy is the easiest to use of all the different atherectomy devices. It's very intuitive because you can use it over any wire in either an RX or over-the-wire system. And the setup for using laser atherectomy is very straightforward, as well as a good selection of different sized catheters. So that, in my opinion, the learning curve for using laser atherectomy is fairly simple, probably on the order of 3 to 5 cases. What was the aha moment when I realized that laser atherectomy could significantly alter my practice? Well, I think the most definitive example of that is that laser atherectomy can have a very important role for treating otherwise uncrossable lesions. So, for example, I can recall a case where a patient had a severe 99% stenosis in the circumflex artery, and it was possible to cross the artery with a wire, but it was impossible to cross the lesion with any other type of support catheter despite multiple tries. For that reason, I utilized a coronary ELCA laser in order to soften the plaque and cross the lesion. And after having struggled for half an hour to cross the lesion, turning the laser on for just a simple 20 seconds was enough to soften the plaque and make it possible to subsequently pass other devices and complete the case. So these kinds of cases where laser atherectomy makes the difference between failure and success, I think are very dramatic and have a lot of implications for optimal patient treatment as well.
The laser learning curve is very straightforward. I mean, delivery of the device is almost like delivering an IVUS catheter. There's not much to it. There's a little bit of teaching in terms of what settings and fiber sizes you might use in a native artery versus an ISR lesion, some coaching around that. But after we've helped colleagues do 1 or 2 cases just in terms of talking them through it, they readily achieve independence and are going on their 3rd and 4th case without much coaching or commentary from a colleague.
Well, when I think about the laser learning curve, I consider it in comparison to other atherectomy devices, and frankly, laser atherectomy is the easiest to use of all the different atherectomy devices. It's very intuitive because you can use it over any wire in either an RX or over-the-wire system. And the setup for using laser atherectomy is very straightforward, as well as a good selection of different sized catheters. So that, in my opinion, the learning curve for using laser atherectomy is fairly simple, probably on the order of 3 to 5 cases.
So laser atherectomy has 2 main mechanisms of action. The first is that the vapor bubble of light is able to vaporize or atomize tissue. So it debulks tissue, be it neointima, be it clot, be it lipid within an artery. The second mechanism, which is one of the more newly recognized mechanisms, is every time the laser fires, which is it's dependent on the rate that you set it at, there's an important acousto-mechanical effect, which emanates into the artery wall and is able to change the compliance of tissues. It modifies plaque, it fractures calcium, and allows you to actually change compliance. You can get better expansion of deep wall elements such as calcium. So laser cases are relatively straightforward and short. If you compare it to other atherectomy cases, I mean, it's easy because you can use the same wire you already have down. You don't have to change for a rotowire, you don't have to change for an orbital wire. And so that part of it is just very expeditious. Get the wire across if you're going to laser. As soon as the machine turns on and the laser is calibrated, you're ready to go. The length of the case is really dependent on complexity. And we use it from things like impenetrable proximal caps and CTOs, which tend to be longer cases because of the other aspects of it. But in things like ISR, where we're having trouble expanding stents, it actually makes the cases quicker. If you take a non-compliant balloon up and it's not releasing, you would go through many maneuvers of trying high pressure balloons, rupturing some balloons, iterating. We don't do that anymore. We put a laser down, we laser aggressively in stent restenosis. So there is, the little bit of time it takes for rolling it in the room, turning on the setup is really made up with regard to the fact it can help get cases done in a much more expeditious fashion when you're struggling with non-compliant tissue such as unreleasable stents, unmodifiable proximal caps, or inability to get gear across if a wire is already down.
Well, laser cases in general actually can be really a quite short segment of an overall case. Typically, because we use laser in complex cases, these may be overall difficult cases. But in reality, the length of time that's necessary to use a laser is often on the order of only 1 or 2 minutes. In the coronary arteries, typically 30 seconds to 2 minutes of laser atherectomy in short pulses of 10 seconds each is sufficient to ablate or modify the plaque of interest. In the lower extremities, we use laser because of the longer length of the arteries. It may take 3 to 5 minutes in order to ablate the area of interest with a laser atherectomy catheter. But overall, this does not add significant time to the overall case, and in fact, I think actually speeds up cases by simplifying an otherwise complex case.
Was back at in London at St Thomas's. We tended to use it only for vein grafts, but my really kind of revolutionary moment was when I had a non-crossable lesion, and I thought, well, why don't we try laser for this? It just intuitively made sense, and sure enough, the wire was down, none of the balloons were crossed. This was back in about probably 2007, 2008, and with the 0.9 catheter, it just smoothly went across. I could follow it up with balloons, and we got the case done. Very effective, very efficient. But the really, really aha moment, I guess, for me, was when I had an underexpand, my first real case of an underexpanded stent, where I put the stent in and it was underexpanded. And when I brought the patient back, I tried everything to get the stent up, brought the patient back, used laser, and within about 10 minutes using it, I could then expand the stent. And to me, that was like amazing, because I'd never been able to do that, or considered being able to do that. So that was quite an amazing moment. This case is an 80-year-old patient with a tight proximal NAD stenosis, which had a significant FFR at the time. And despite 2 burr rotablation and a cutting balloon, you can see on the IVUS there was still a sort of napkin ring of calcified tissue that I could not fully expand. I made the mistake back in 2009 of putting a stent in with the concept that I could go up to higher pressure and perhaps expand that lesion. But all that happened, of course, despite an OPN to 40 atmospheres, was that the stent didn't expand. That then meant I had to bring the patient back, and after debate and some discussions with colleagues internationally around the world to try and work out how best to treat this, because at 2009 we really didn't have very good solutions for treatment, we decided that laser would be the best option. So that was the IVUS at the start of the case. You can see a very, very, very constricted stent. Now I took a 0.9 and a 2.0 laser catheter, and after 10,000 pulses, the balloon that I previously hadn't expanded very easily. And we got a very good result within the stent with reasonably good expansion and a good CSA on IVUS. So we published this one. This is a case report in neurointervention. As colleagues from Milan have published the Element Registry, 28 patients and you can see the results there showing reasonably good efficacy and safety. Importantly, as this case report illustrates, the benefit in cross-sectional area gain is only achieved when you've used the balloon after laser. So you perform the laser and then you take a one-to-one non-compliant balloon, and that's where you get the expansion and you get the improvement on intracoronary imaging. And in this case series from recently published, it's quite a nice little series of 81 cases where 23 laser was performed. It really defines the fact that it is very effective, and it appears to, from OCT analysis, to affect the peri-stent calcification.
Hello, welcome to the Royal Bournemouth. I'm Peter O'Kane, I'm a cardiologist down here, and I'm taking part in a really excellent educational event on the 4th and 5th of November, Optimal Online and Wonder Medical. And this is an event talking about complex coronary artery disease and its treatment. And I'll be discussing laser firing blanks, the combination of laser and shockwave therapy in these calcific complex disease. Part of a session with a live case from Bristol, which I know will be really good. So please come and join us for this excellent meeting. Look forward to seeing you there.
Can you give any tips to people who are starting up with this technology? Tell me about what you think their learning curve should be and how they should progress in using the kit.
Mm-hmm. Yeah, absolutely. So, the learning curve with laser, in my opinion, is actually fairly simple. It's probably on the order of 3 to 5 cases.
Right.
I think, if you're first starting to use laser in the coronaries, an in-stent restenosis case is a good place to start because you have a clear metric that you're looking at with regards to the stent expansion and the neointimal ablation. I think that it's very easy to use because literally once you do have the machine in the room, it takes only about 10 to 20 seconds to calibrate the laser and then start using it. And the technique of laser atherectomy is something that we've really refined over the course of the last decade. And I think what is really the most important aspect of the technique is very slow advancement of the catheter on the order of 0.5 to 1 millimeters a second.
Right.
Yeah, by doing that, it really allows the laser to ablate whatever is in front of it and thereby minimizes the chances of embolization and also gets a more effective result.
Well, I'm delighted to be joined today by Dr. Erin Armstrong, who is an interventional cardiologist working in Denver, Colorado, and we're going to be talking today about laser atherectomy and his experience of using it. Thanks for joining me, Erin.
Thanks for having me.
So you're quite an experienced operator in using laser atherectomy. Tell me about your experience of how you got into using the kit and in the type of cases you use it.
Yeah, absolutely. I've been using laser atherectomy for about 10 years at this point. I had a fair amount of exposure to using laser atherectomy when I was doing my interventional cardiology fellowship training. And what I found from early on was that it has an important place in the treatment of complex coronary artery disease. And I think the The multiple applications of laser atherectomy, I think, make it a very important part of my overall toolbox in the cath lab.
I think the most common misconceptions about laser atherectomy is it's hard to use, it's voodoo, it's only used in complex PCI centers. That's anything but the case. The learning curve is quite quick. It's incredibly safe if you use it in a rational way. You know, I think years past, probably before I was even an interventionalist, laser got a bad name because physicians were typically using large fibers and small arteries and lasering on contrast, which actually amplifies tremendously the amount of energy. And if you laser on contrast in a native artery, the risk of perforation does go up in that case. And so fast forward 20 years later, we know how to use it in a safe manner. And we laser on saline routinely because the level of energy is more measured. And it's very safe when used that way. And so I think the safety profile has been fine-tuned in a way where with regular, judicious, and rational use with good practice, it's a very safe and easy device to use. People, I think, overcomplicate it too. It's a very simple device to use. You know, there's a couple fibers, there's multiple settings, but after you've done a few cases and gotten a little bit of coaching in terms of the best practices nationally that are being used, it's relatively straightforward. We have recommended settings and fiber sizes for native, similarly for ISR, and the learning curve is incredibly quick to get up to speed on. And so the complexity is not there and the safety certainly is. And those are the two main misconceptions that we talk about when we teach people who are new users. And they climb the learning curve very quickly and are on their way to being independent in no time.
Over the last 20 years. It's been around for that sort of period of time. So the system really works. It's ultraviolet light. The wavelength is 308 nanometers. It's pretty short penetration. So it doesn't damage really deep tissues. It really just sits fairly shallow. It works really by three different ways. So there's a light pulse, obviously, from there, which gets absorbed into tissue, and that helps to break down heterogeneous tissues, so both soft and sort of harder tissue. But I think increasingly we're aware of this sonic wave, which occurs, or acoustic wave, which that is much better for the harder material. That kind of filters out. It probably is going in a more sort of perpendicular, or sort of a more parallel fashion to the vessel, because it's not going to really go out to the sides. But that seems to ablate some of the harder tissue. And then the last mechanism of action is that around the catheter tip there forms a vapor bubble, which is like a sort of umbrella around the tip of the catheter. And that helps to kind of ablate the tissue, recycle it into tiny, tiny particles, and they go downstream and get absorbed in the reticular endothelial system.
So what setup is required to use laser atherectomy in a case? Well, first, it's necessary to use the console, which does need to be brought into the room and plugged in. It does require 5 minutes of warm-up, so if you're considering using laser, then it's good to plan ahead to have the console ready. After that, it's necessary to decide on the size of the catheter to utilize, which come between 0.9 and 2.3 millimeter sizes. The 0.9 and 1.4 millimeter sizes are especially useful for coronary interventions, whereas the 1.4, 17, 20, and 23 are useful for the treatment of peripheral vascular interventions. And once you've decided on the catheter, it takes a simple calibration with the device that takes about 10 seconds, and then after that it's possible to go ahead and utilize the laser. How does laser atherectomy actually work? Well, that's an interesting question because laser atherectomy has been around for more than 2 decades. And I think fundamentally we all understand that laser is a photoablative energy that can break molecular bonds approximately 0.5 to 1 millimeters proximal to the site of the laser catheter. We also now understand that laser atherectomy works not just by breaking those bonds, creates a bubble that is up to 2 to 3 times larger than the catheter itself. This is one way that is the mechanism for why laser can ablate a bigger area than the size of the catheter. Over the past few years, we've actually learned other interesting aspects of laser atherectomy mechanism of action. And one of those is that there's actually a sonic pressure wave that sends off with the laser prior to the formation of the steam bubble. And this is one explanation potentially why laser atherectomy can be effective in the treatment of calcification by promoting a sonic pressure wave that can crack calcium or other areas of underexpansion.
You mentioned calcium, and you mentioned that the laser is really helpful in calcium cases. Tell me about your experience in that situation. When would you decide to use, say, a rotational or an orbital versus a laser?
Yeah, I think that's an excellent question. I mean, orbital atherectomy and rotational atherectomy were purpose designed for treating calcified coronary lesions, and I think they're very effective in that. I think those devices have some limitations, one being that they require the use of a specialized wire.
Right.
That is actually, I think, one great advantage of laser atherectomy is you can advance it over any 014 wire and don't have to lose wire position if you decide to use the laser. But laser atherectomy, especially if you turn it up to a high rate, then it can modify the calcium. It also, because the mechanism the laser works by is creating a vapor bubble that expands, that bubble can modify calcium, and especially calcium that's deeper in the artery, for example, and preventing expansion. And in the last few years, we've actually learned that even prior to the formation of that vapor bubble, there's a sonic pressure wave that occurs when the laser fires.
Right.
And that pressure wave is essentially a shock wave that can expand.
Right, it's almost a resurgence of this technology, isn't it, in these really quite challenging and complex cases. So that's absolutely fascinating to hear about the use in calcium and ISR.